Thank you very much, Udana. I'm very happy to be here again, and it's a great honor to share some of the simple experiences that I had in clinical scanning, mostly on the topic of CNS infections. I will try also to cover a little bit about the infection control protocols after some feedback from the focus group that we had a short meeting prior to this presentation. So I hope that it will be useful to you. I have a few disclosures to do with some research that is not related to the current presentation. I'll talk a bit about the applications and techniques in CNS infections and launch into a superficial coverage of some of what the radiologists use image pattern recognition to make diagnosis of the common patterns of infections and the features that we extract from the images, including meningitis, particular TB, because that may be of interest worldwide. We have abscesses and other non-abscess ring-enhancing lesions, including parasite infestations, which are not uncommon in the global south, viral encephalitis, and finally HIV and iris, which is a phenomenon that sometimes occurs. We'll talk a bit about how can radiologists help in an infectious disease outbreak and the infection control procedures, specifically for COVID-19 as an example. So we'll start with the techniques that we have. But before, let's go into the background of infections of the CNS. Now, when it comes to brain diseases, trauma is very common. Cerebrovascular diseases is also very common. And then we have degenerative, dementias, psychiatric. Amongst all these pathology textbook chapters that we come across, infection is very much rarer. Tumor is also very unusual, but there is a great deal of research, funding, resources, a lot of projects to look for perfusion, DTI, spectroscopy, to study tumors, not so much for infection. It has very poor research data, especially in terms of primary radiology data. We don't even know the sensitivity and specificity of some of the findings that we can see. Randomized controlled trials are very limited. There is some research going on in HIV and tuberculosis, but not much for some of the other bacterial meningitis and rarer diseases. There is some literature in the outbreaks, especially since COVID, but we'll talk about that a little bit later. So the approach that radiologists can use include the textbook according to the pathogen. We divide the infectious agents into bacteria, viruses, fungi. We can also divide the anatomical decisions, where we scan the brain, the spine, the head and neck, ENT region. But we have to be aware that many of these subjects cross the boundaries that I've just spoken. For instance, HIV involves all the different opportunistic infections and some tumors as well. And of course, pediatrics will have another ballgame altogether. This makes much of the radiologist's work an oversimplification on the pattern recognition, which is problematic because there is an overlap in the features, in that many meningitis, we can't tell which organism is causing it. There may be a common pathogenesis and therefore common MRI appearances. And it's important for us to have pathological confirmation because the treatment depends on correct identification, particularly of bacteria, which can be treated if we know the antibiotic sensitivity. So a lump puncture for cerebrospinal fluid investigation, obtaining the CSF is still vitally important. However, an invasive process like LP is much harder to obtain in my hospital compared to an MRI, which is more common to be requested and approved. So I'll anchor the three different types of pattern recognition on meningitis pattern, abscess pattern, and encephalitis pattern. It'll blend, my talk will blend the pathogen classification, and I want to emphasize on the multidisciplinary team approach, where the radiologist interacts with the neurologist, the neurosurgeon, if there is biopsy that's necessary for the abscess assessment, the infectious disease specialist, and during outbreaks and pandemics, the public health officials. Amongst the pulse sequencers that we typically order for MRI include the T2 or the FLAIR and contrast-enhanced MR. Among the contrast-enhanced MR, the T1 weighted contrast-enhanced or the FLAIR after contrast are both acceptable. I highlighted diffusion and SWI because they are the currently newish types of pulse sequences that are extremely sensitive to abnormalities, particularly during the time of COVID. So we shall see examples of how these are helpful and useful for identifying small lesions. Once in a while, it may be necessary for us to obtain MR angiogram and venogram for complications. In terms of advanced MR, diffusion is no longer considered advanced, but a standard pulse sequence. Diffusion tensor and kurtosis is not very often used. Perfusion, particularly dynamic susceptibility contrast enhanced perfusion MRI, less so ASL, may be helpful when there is ambiguity between infectious causes of brain lesions versus non-infectious, such as brain tumors. Likewise, with MR spectroscopy, as shown in this spectrum without an abnormal high choline level, meaning this is unlikely to be a neoplastic process, but lactate and some lipid breakdown products from necrotic, probably infectious cause. I mentioned contrast-enhanced MR. We can use not just the T1 weighted post-contrast, but also contrast-enhanced FLAIR images, which may be helpful. And lastly, the black CSF vessel wall imaging, which I will show you an example later on. So these three methods of obtaining a contrast-enhanced study where we are looking at high signal intensity of blood-brain barrier breakdown, we have choices in increasing the sensitivity of contrast-enhancing lesions at our fingertips. And here's what I'm describing. This is a contrast-enhanced FLAIR pulse sequence, and this is what we are used to viewing, which is the contrast-enhanced T1 weighted MR images, specifically a spot gradient echo, which is a little bit less sensitive. And here you can see that there's diffuse dural contrast enhancement and some leptomeningeal contrast enhancement in a patient with meningitis. On the FLAIR, you can also see that the enhancement is accentuated in some of these areas, and specifically in the CSF in the prepontine system, abnormal contrast leakage and enhancement is very much more noticeable than when compared with the T1 weighted. So in some hands, contrast-enhanced FLAIR has been very helpful in bringing out the abnormalities. However, in our center, it isn't commonly practiced. We usually just acquire the T1 weighted because the flare has sometimes got a problem with false positive findings. So it depends on the radiologists in your hospital, how comfortable they are and how used to this pulse sequence they have become. So let's dive right into the bacterial meningitis in the pattern recognition of leptomeningeal abnormality. So when there's infection and inflammation of the meningeal surfaces, we usually see leptomeningeal contrast enhancement, which is reflected as the gyriform curvilinear enhancement of the leptomeningeal surfaces. Sometimes when the bacteria invades into the brain and causes cerebral inflammation called cerebritis, there can also be abnormal enhancement of the brain parenchyma as seen here. Now, this is after contrast injection. If we don't perform contrast injection and we depend on T1 or T2 weighted MR images, the leptomeningeal inflammation isn't visible. However, when there is pus in the subarachnoid space in meningitis, flare imaging may be helpful, but the diffusion weighted MR imaging is very, very sensitive to small amounts of pus. As you can see here, these tiny pockets of high signal intensity in the subarachnoid spaces outlining the gyriform septal sulcal areas of pus are very well demonstrated on DWI. In addition, sometimes, like in this particular case, you can also see subarachnoid pus within the lateral ventricles of the dependent portion of the occipital horn, which is where we would see the smallest areas that can be detected by the naked eye. This patient had meningeal features, but it was mistakenly reported as normal. It was only on review that we saw, and if we don't look for it, we won't be able to see it. So DWI is very helpful for tiny areas of pus collection. If meningitis is not well treated in time, the invasion of the brain, either hematogenously or by direct entry, as in this case, will result in complications such as cerebral abscesses. And here in the temporal lobe, there is a rounded lesion with surrounding edema, with abnormal ring enhancement in this patient with an abscess. The cause of this abscess is otitis media, infection of the mastoid air cells and the middle ear, with direct extension into the underlying temporal lobe. And here you can see that the diffusion weighted MR image, which we recognize here as very low resolution 64 by 64 matrix, and the increased susceptibility artifact at the airborne interface, making this lesion a little bit difficult to perceive, but you can see that there's high signal on DWI in this pus collection caused by cerebral abscess. I think my slides have been misplaced. So I've moved forward to the assessment of abscesses versus tumors. So this describes two patients, the patient above and the patient below. One of them has an abscess, the other has a tumor. So here is a patient who has a ring enhancing lesion. This is also ring enhancing. The T2 Both show high signal intensity and surrounding cerebral edema. Which patient has the abscess and which patient has the tumor? We will use diffusion-weighted MR imaging, and this is a patient with high signal intensity, restricted diffusion. This patient is unrestricted, no high signal on DWI. This patient has an abscess. This has a non-abscess, probably tumor. This feature, where DWI can be very helpful to detect abscesses, works in untreated patients. Once antibiotics are given, this high signal intensity restricted diffusion will start to normalize and go away. Here's another patient without direct invasion, but with a known liver disease, which ultrasound suggests an abscess. Again, multiple ring-enhancing lesions with T2 high signal intensity. On FLAIR and on diffusion-weighted MR imaging, this turned out to be multiple abscesses. In addition, pus located in the subdural or epidural spaces, which are called empyema, follow the same basic principle and display restricted diffusion on DWI. So let's take a short segue, apologize for my disorganization, and go into the question of TB meningitis. So in TB meningitis, there is a finding of abnormality of enhancement of the meninges, as we have seen in typical bacterial meningitis. However, when we have the diagnosis of TB or a possible diagnosis of TB, it is important because antibiotics are not going to be effective, and TB requires treatment with anti-TB chemotherapy. So if there's any possibility that the patient has TB, we should consider that diagnosis. And here is the definition according to the New England Journal criteria for suspecting a probable TB, including active pulmonary tuberculosis on chest X-ray, positive acid-fast bacillus in any specimen except the CSF. So if we have sputum, urine, or blood acid-fast bacillus, it adds to the probable diagnosis, and of course, clinical evidence of other extrapulmonary TB, such as intestinal or spinal TB. So once these are probable in one or more of these characteristics, we should start implementing TB treatment for the brain meningitis, as well as the extrapulmonary focus of TB. This is acid-fast bacillus in any specimen that is not CSF. If the CSF is positive, then it is upgraded to a definite diagnosis of TB. And if none of these is positive, the suggestive features allows us to make a diagnosis of possible tuberculosis. Not probable yet, possible. So what are some of the features in imaging that will help us to suspect that we are dealing with TB meningitis? The meninges are very florid in their response to TB. If we see thick exudative basal contrast enhancement, such as you see here, we should think about TB. In addition, the presence of hydrocephalus due to obstruction by exudative meningitis and small tuberculomas, as well as finally acute cerebral infarction from vasculitis, should allow us to suspect that the meningitis may be caused not by a pyogenic organism, but by TB. Nowadays, the PCR analysis, if available in your hospital, will be very much more helpful. And as I've said, the reason for that is that antibiotics will fail if the patient has TB. We need to start early, and we need to start steroids very quickly to make sure that there are fewer complications arising. So in addition to hydrocephalus, one of the most feared complications is cerebral infarction. Here you can see that there is meningitis, meningitis-induced vascular narrowing and occlusion, giving rise to infarction of the MCA territory on one side and the perforators that feed the basal ganglia and corona radiata on the opposite side. The cerebral infarctions in a patient with TB, meningitis, and vasculitis can be subtle. They can affect small territories, and they can also give rise to pus in the subarachnoid spaces. So the DWI and the MRA are helpful in making the diagnosis. And here is an example of the black CSF before contrast enhancement and after contrast enhancement. So before contrast enhancement, we can see that the middle cerebral artery in the Sylvian fissure can be visualized with the black lumen of flowing blood and black CSF. And after contrast enhancement, we'll note that the middle cerebral artery wall shows irregular, eccentric, abnormal contrast enhancement of the wall. And this is an example of direct visualization of the vasculitis causing infarction. And don't forget, of course, the spine in TB can be affected, as well as giving rise to psoas abscesses. So just a short note about leptomeningeal contrast enhancement versus dural contrast enhancement. And here the arachnoid matter is enhancing. Here the thick fibrous dura is enhancing in a very diffuse way, caused by different causes and different diagnoses. So here's an example of if there is exudative leptomeningeal contrast enhancement plus hydrocephalus, think about tuberculosis. The differential diagnosis I won't go into. The leptomeningitis can also be caused by cancer, and diffuse dural enhancement is not always infectious, but can be caused by intracranial hypotension. So the next pattern, we will come back to the idea of brain abscesses and the differential diagnosis of ring-enhancing lesions. So I've mentioned that the classic ring-enhancing lesion is abscess, and we can use diffusion as a differential tool for making the diagnosis. Pyogenic abscesses are not the only cause of a ring-enhancing or nodular-enhancing lesion. Tuberculomas and TB abscesses, fungus, and toxoplasmosis in HIV/AIDS can also give a ring-enhancing lesion, as well as parasites, classically neurocysticercosis, as I will show you later. Other non-infectious ring-enhancing lesions include metastasis, primary tumor such as glioblastoma and lymphoma, and of course, subacute infarct and subacute contusion and demyelination. In ring-enhancing lesions, an abscess does not have elevated RCBV or increased enhancement in the wall, unlike metastasis and primary tumor. In terms of elevated choline in tumors, but no elevation in infection. So sometimes we can use that as a measure to distinguish them. Let's talk about parasitic diseases, specifically neurocysticercosis and schistosomiasis. So the pork tapeworm is endemic in many parts of the world, and the CNS infection of cysticercosis is the commonest cause of seizures worldwide. The classic description of the brain appearance of neurocysticercosis is divided into different stages with different appearances on both CT and MRI. It starts off as a simple cyst without edema or enhancement, moving on to a vesicular colloidal contrast-enhancing and edemated cyst when the parasite dies. It retracts and becomes nodular granular with decreasing vasogenic edema and blood-brain barrier breakdown, finally mineralizing into a calcified, inactive chronic lesion such as this. So the appearance of two different stages of appearances, such as the active colloidal vesicle enhancing edematous lesion and a chronic lesion or another lesion with a cyst, is a very good marker and a clue that we're dealing with neurocysticercosis, such as in these two patients. One on the top row showing an active lesion with ring-enhancing lesion and edema, and a second non-active and a third non-active cystic lesion. In a different patient in the bottom row, sometimes the edematous contrast-enhancing lesion can show us a degenerative scolex. Now we come to the next parasite that we can see. This, fortunately, does not happen in Africa, but in Asia. There are 3 different species, and Schistosomiasis japonicum is the example that I'm giving here, where on MRI, there is a very large complex mass comprising multiple tiny nodules and including linear enhancement looking like a bunch of grapes. The importance of this lesion is that many of patients will travel from from endemic areas and import the disease into non-endemic areas, such as the United States and Europe. But another species, Schistosomiasis mansoni, can be found in Africa, and Schistosomiasis hematobium, which typically affects the spine, occurs in the Middle East and Africa. Just to backtrack, in terms of parasitology, there are 2 large categories of parasites. One is the multicellular flatworms and roundworms, and I've highlighted cysticercosis and schistosomiasis. But don't forget there are single-cell protozoa, which affect many different places, including trypanosomiasis. And here I'd like to make an appeal. Anybody who has an example of a patient with brain involvement of sleeping sickness, please contact me. I've been trying in vain for the past 5 years to try and get an example. I've got South American Chaga disease, but no luck in finding African sleeping sickness. These single-cell protozoa also include malaria, toxoplasmosis in the HIV section, we will cover it, and of course, amoebiasis. Here in HIV infection, we will cover specifically opportunistic infections. In full-blown AIDS, if the patient is not treated with ART, opportunistic infections are the most common CNS disease, especially toxoplasmosis. And in our center, our infectious disease specialists will treat a patient who has CNS findings with empirical tours of antitoxo treatment, and then do follow-up MR. TB is also very important, especially multi-drug resistant tuberculosis. In addition to toxoplasmosis and TB, there are, of course, other infections such as bacterial and fungal infection. Here's an example of a patient with toxoplasmosis with a ring-enhancing asymmetric target sign, as you can see in these two lesions in different patients. As I mentioned, other opportunistic infections like Cryptococcus and Aspergillus can also affect them. And finally, lymphoma, primary CNS lymphoma, can be seen in patients with HIV and must be distinguished from toxoplasmosis. There are two complications in HIV that affect the white matter. They are the neurocognitive disorder, known as HAND, or previously HIV-associated dementia, and progressive multifocal leukoencephalopathy, PML, which is a demyelinating disease caused by the JC virus. This is an example of a patient with a lesion in the basal ganglia, which was thought initially to be toxoplasmosis, but did not respond to an empirical course of anti-toxo treatment. When we called the patient back, we decided to perform spectroscopy. It showed high choline, and the patient was biopsy proven to be lymphoma. I mentioned the white matter abnormalities. When the virus, the HIV virus, attacks the brain and there is no opportunistic secondary infection, the virus can cause degeneration, and it can be visualized in the white matter, which shows high signal intensity. This patient went on HART, and the cognitive disorder was improved. The MR findings were slightly improved after treatment. Compared to PML, which is more focal compared to the diffuse white matter abnormality we saw previously, and like most other demyelinating conditions, PML does not occupy space and does not often have abnormal contrast enhancement. So the white matter demyelination is usually focal or multifocal with T2 high signal and no contrast enhancement. Once in a while, we will come across the problem of iris, which is an immune reconstitution inflammatory syndrome. This happens when a patient starts antiretroviral treatment and the CD4 count improves. The virus starts, the HIV virus starts to decrease in viral load, and there is an intense inflammatory response, which we will visualize as florid enhancement, showing up as paradoxical MRI or clinical worsening, despite the fact that the patient is actually getting better and can mount a sufficient immune response. So as radiologists, it's important for us to recognize that, and to recognize also that TB often results in iris, which means that our infectious disease experts recommend starting anti-TB treatment first and then defer ART therapy for a few weeks until the TB treatment starts to show effect before having this intense inflammatory response. Because otherwise, if we see iris features, even though we suspect it could be iris, it may be very difficult for us to rule out another active infection, and we may be forced to suspend ART while we sort the patient out. So if we have this kind of situation, it's very important to rule out opportunistic infection and drug toxicity. This makes it a big headache for our multidisciplinary team discussions. So very difficult problem, not an easy solution. Viruses. Let's talk about herpes simplex virus infection. This is a pattern that is classically going to involve the temporal lobe cortex in the hippocampus, the medial temporal, sometimes also the lateral temporal, and the inferior frontal region. Sometimes there is high signal intensity on DWI, but we can see that the flare usually shows us very good signal to noise ratio, and it doesn't have the glare of the CSF high signal on a conventional T2 weighted MR image. And here you can see bilateral involvement of the temporal lobes and the hippocampus, as well as some regions of the frontal lobe. So this is the classic herpes simplex virus encephalitis. And here again is the T2 weighted MR image. Very difficult for us to discern the involvement of the thickened and high signal intensity in the cortex with very blurred outline, but on flare, very clear delineation of the affected cortex. Okay, so that was the example of herpes, where there is a pattern that we just saw. There is another pattern that is typical of virus infections amongst the very many viruses that can result in brain lesions. The other group where we typically see would include the arboviruses, which are arthropod-borne mosquito or tick infestations, and they classically include Japanese encephalitis, West Nile virus, and dengue virus. These sometimes, but not always, show a pattern of thalamus involvement and sometimes of the basal ganglia. They may also show white matter lesions, but without contrast enhancement. Typical Japanese encephalitis involves the thalamus bilaterally on flare, and here is the DWI, but does not show restriction in diffusion. This is probably some degree of T2 shine through. On the SWI or gradient recall echo, they may show some areas of hemorrhage susceptibility. It's important for us to distinguish this from an immune-mediated post-infectious ANE, which also confusingly affects the thalamus and can also hemorrhage. So let's talk about how radiologists can help and what we can do in an infectious disease outbreak, specifically focusing on zoonotic viruses. Radiologists should be aware of the typical MRI patterns and the differential diagnosis. We saw herpes simplex, schistosomiasis, neurocysticercosis, etc. We saw how diffusion, weighted MR image, and to a lesser extent, SWI during the COVID-19 pandemic has allowed us to see tiny lesions very clearly. And of course, we can do collaborative research. And these are some of the examples of viruses that have skipped and crossed from their animal hosts, jumping the species barrier into humans. Bats are a constant reservoir of horrible viruses. And here in Malaysia and in Singapore, Nipah virus was found in fruit bats the infected fruit was dropped into pig rearing farms, and these affected humans in Malaysia and abattoir workers in Singapore. And so we scanned many of these patients. Next came SARS, where the viruses that lived in bats crossed into China and was one of the first pandemics in 2003. In Middle East, there was an outbreak in Saudi Arabia that spread to many different countries and as far away as Korea. And of course, we remember Ebola from a few states in Africa. And most recently, COVID-19 with a suspected reservoir in bats crossed the species barrier. These zoonoses live in animals and jump the species and have been crossing the species barrier for a very long period of time. There is a complex multidisciplinary public health threat, and the WHO, of course, declared pandemic in many of these, and most recently, Mpox virus. The spillover effect starts with toxoplasma from cats into HIV-exposed individuals, to rabies viruses and E. coli and leptospira infection from rats. In many parts of the world, I've mentioned the Hendra and Nipah viruses, SARS. Other pandemics, such as the H1N1 and the other outbreaks that we have had the misfortune of receiving, have been seen in many places. And in Singapore, our experience with the SARS outbreak in 2003 and our caution with the Middle East respiratory virus enabled us to prepare for the COVID pandemic in terms of our isolation and infection control. So the following slides are courtesy of Ms. O, our Chief NNI MRI technologist. In brief, it describes some of the MRI infection control, specifically in COVID-19. So at the height of the pandemic in 2021, the journey of all COVID-19 positive patients who required an MR study, the steps in terms of extra manpower, scheduling, porterage, and the different challenges are going to be described in this talk. The background is that MRI safety is important to protect not just the MRI staff, but also the other patients in the hospital, which will be using the MR scanner before and after infected individuals. This infection control safety measure is layered on top of the standard MRI safety measures, including the metal and pacemaker precautions. So, among the standard infection control measures in our hospital include the personal protective equipment of radiographers, as well as providing for masks and N95 respirators, the infection control gowns, etc. In addition to providing those, what we found most important was the staff training and refresher reminders of hand washing, personal hygiene, PPE, and specific training on how to put on and take off the PPE, and strict drills organized by our nursing sister. I don't know about you, but in our department, we have a very strict nursing sister who controls everybody's ID training very, very well. Now, in addition to these standard PPE, we also have air exchange. And in the MR scanner, there is free exchange between the scanner room and the technical room because people move about to and fro freely. So that means that the air exchange needs to have additional protection using these portable HEPA filter units for recirculated air. We vacate the air in the room after we scan a positive infected case before the next case. And we have, of course, cleaning measures, as well as trying to cluster the COVID positive patients towards the end of the day and shutting down the outpatient or inpatient scanner for the rest of the night and continuing the inpatient service on a different machine that is not affected by this. So selection of the scanner may be a luxury that not all of us have, but these are all measures that will be very helpful in protecting our staff and giving better confidence. So at the height of the COVID-19 pandemic, an approval for consultation and the appropriateness of requests is usually the prep that they have to make between the communication between the referring clinical service and the radiologist. The transport needs to be arranged. The procedure needs to be done at the MR room to clear the room of any extraneous fomites and unnecessary presence of articles. The manpower will lay on protective plastic sheeting. Transportation is coordinated with nursing, and the patient is usually listed for an appointment later in the day, and with the on-call radiographers being aware of the arrival of the patient. So all unnecessary equipment, especially wheelchairs and not being used, are removed. Sheeting is laid on areas that are difficult or fragile to be cleaned, and coordination is important between all departments. Cases must be approved. Those that can wait will wait until there's de-isolation, but urgent cases, of course, need to be performed. Most outpatients at 6 p.m. would have left the department, and the tempo of the department will be much, much less intense. Mistakes will hopefully be fewer, and the other scanners may still be operating in other parts of the hospital. The existing hospital staff strength to prevent mishaps also needs to be thought through. We currently have a minimum of 2, sometimes 3, and the on-call radiographer will be required to prepare for overtime in order to maintain the service. So there's been a lot of challenges, as this slide shows, that there's delay, coordination, can't find the necessary equipment. Sometimes there's more than one case. We don't hear them for a long period of time, and then they suddenly show up. Sometimes there are multitasking that's necessary long-term during the pandemic. This took a huge toll on our staff, and the stress levels all went up. So that's a short segue into infection control. And I'll go back to my pattern recognition and wrap up for the night. And what I've just said is an oversimplification of the pattern recognizing that there is leptomeningeal contrast enhancement in meningitis, small amounts of pus. In herpes simplex virus encephalitis, there is high signal intensity in the hippocampus and medial temporal regions. Abscesses are typically ring-enhancing lesions, but because there's a lot of common pathogenesis, ring-enhancing lesions can sometimes be difficult because there's overlap and specific diagnosis isn't always reliable. Our approach and our techniques, we use a lot of diffusion and susceptibility-weighted imaging, and we looked through meningitis, specifically tuberculosis. We also looked at parasites, such as neurocysticercosis, and HIV, specifically opportunistic infections and differential diagnosis of lymphoma, and immune reconstitution syndrome, IRIS. We talked about multidisciplinary team and radiologists, and zoonotic infections and infection control. So, thank you very much for your attention. I think we have some time to take some questions.